video, we're going to focus on the pharmacologic agents used for the treatment of lung cancer. Specifically, we're going to focus on non-small cell lung cancer, which you'll see abbreviated like this. And we're going to focus on the agents that are referenced or alluded to in the IQ case this week. So non-small cell lung cancer includes several different lung cancer subtypes, with adenocarcinoma being the most common type in this category. So a number of avoidable and unavoidable factors play into the development of non-small cell lung cancer, which we're not going to get into the specifics in this video. Patients may be asymptomatic in early stages, progressing to cough, wheezing, and chest pain, and in advanced stages all the way to weight loss, fatigue, and more obvious extrathoracic symptoms. So just as before, tumor size is going to be combined with information regarding lymph node involvement and metastasis, if present, to determine staging, prognosis, and adjuvant treatment options. So genetic testing can also be used to help identify additional drivers promoting the disease and more targeted agents that might be of value. Now, I left this schematic here as a reminder of all the different anti-cancer options that are available depending upon which cancer type we are talking about. And for lung cancer specifically, we will be focusing on one conventional chemotherapy class. And these are the agents most think of when they think about anti-cancer therapies. We'll also focus on some immunotherapies, which sometimes are grouped with the targeted agents. Sometimes they're over here with the miscellaneous agents. Either works. And then we will finish with a small molecule inhibitor targeting a genetically altered signaling cascade. So moving to our next slide. So we will start off with our conventional chemotherapy class being the platinum-based agents. And these are alkylating agents. And these are also called the platins. And that's because the agents in this class are cisplatin, carboplatin, and oxaliplatin, all which end in this platin ending. So now I do want to take a second just to highlight a bit of nuance with these agents. So I know I said they're alkylating agents. And on UpToDate, you'll see these listed as alkylating agents as well. But technically, they don't fit the full definition to be a typical alkylating agent like cyclophosphamide, which we already talked about. And that's because they're lacking the alkyl group and the typical adduct formation that happens with alkylating agents. So you might also see these listed as alkylating-like agents or as cross-linking agents as well. So just keep that in mind, and once we go over the mechanism of action, that will make more sense. And this is one of the main conventional or cytotoxic chemotherapy classes we have not yet talked about. So just as a reminder, these types of agents are intended to wipe out rapidly dividing cell types, ideally being the malignant lung cancer cells, but we're also going to hit that GI tract, the skin, the hair, and the bone marrow, etc. And again, this is because all of these cell types are very high turnover, so very dependent upon DNA replication. So again, our common ADRs we talked about before with conventional chemotherapies are going to apply here. So now, mechanism of action of our platins like cisplatin, for example. Again, these are alkylating agents that contain platinum, which allows for covalent binding with our purine bases. And this leads to intra and inter-strand crosslinks that lead to DNA breaks and damage that cannot be repaired, triggering cancer cell apoptosis. As with some of the other conventional chemotherapies, there is going to be a risk of secondary malignancy, as well as tumor lysis syndrome, on top of all of those other concerns we have when we're targeting our usual rapidly dividing cell populations. There is also going to be a risk of nephrotoxicity, especially with cisplatin, despite having hydration protocols in place, and these are all going to be renally cleared. The nausea and vomiting with these agents can be very severe to where it can cause metabolic derangements, so we'd need to pre-medicate with antiemetics. And then hypersensitivity reactions are another big concern with these, and this can range from anywhere between 5 to 25% of patients experience this, depending upon which platinum agent we are talking about. And lastly, these are all neurotoxins, with oxaliplatin being the most concerning for this, but there is a risk of ototoxicity, peripheral neuropathy, and cold intolerance that can be severe enough to cause discontinuation of these agents. Now, as I kind of alluded to, the risk of all of these is going to vary a little bit with each agent, but these are some of the more important ADRs to be aware of. Now we will shift gears to our immunotherapies, which you will see again in Block 5. So right now, just focus on the general understanding of this mechanism, and you can revisit the details once you have a stronger immune system foundation in Block 5. The first agent we're going to discuss is ipilimumab, which is a monoclonal antibody against CTLA4, or cytotoxic T lymphocyte associated protein 4. Now, there are two types of immune cells we need to introduce. So the first are going to be our T cells. So think of these as effector cells. And our antigen-presenting cells, think of these as sounding the alarm for the rest of the immune system to kick into gear. Now, in order to get full T cell activation against a cancer cell, following the antigen-presenting cell presenting part of the cancer cell to it, a T cell's T cell receptor must first interact with antigen-bound protein on the surface of our antigen-presenting cell, or APC, but this must occur alongside a co-stimulatory signal that's produced from the interaction of CD28 and B7, which I'm showing you here. Again, the specifics are not as important at this point. So once we have both of these signals, we get appropriately activated T cells that can go on to mount an immune response, in this case directed at the lung cancer cells. However, our activated T cells have to have an off switch or a checkpoint to ensure that appropriate immune response is mounted for the right amount of time. So when it's checkpoint time, activated T cells will upregulate expression of CTLA4 on their surface to where this protein can actually come in and outcompete CD28 for binding to B7 on those antigen-presenting cells. This eliminates that co-stimulatory signal that's needed for T cell activation and turns off the immune response. This is where ipilimumab comes into play, our monoclonal antibody. By administering this agent, it can bind to CTLA4 and prevent its ability to actually bind that B7 molecule on the antigen-presenting cells. This way we prevent the T cell off switch, so the immune response mounted against the lung cancer can actually continue to be perpetuated. The pharmacologic considerations for this agent include the risk of hypersensitivity, reactions, and indirect immunostimulatory effects. This means we increase the risk of triggering autoimmune reactions and conditions. So if you look up the precautions and ADRs listed for this agent, you will see a good majority of them involve autoimmune mediated inflammation, and this is going to be the primary concern for this agent because we are taking away that checkpoint. Our next agents are also monoclonal antibodies, and they target either PD-L1, which I'm showing you here, or PD-1, which is on our T cell, which I'm showing you here. And this stands for programmed cell death protein 1 in this case, or programmed death ligand 1 in this case. And nivolumab is our example, and it targets the PD-1 side of this interaction. So PD-1 can be found on the surface of our T cells, remember, our effector cells, and PD-L1 can be found on the surface of our antigen-presenting cells, or our APCs. And these are, again, immune checkpoint proteins. So when PD-1s interact with PD-L1s, this leads to a downregulation of T cell activation so that we don't get an autoimmune response against autoantigen that's being presented by the antigen presenting cell, which promotes self-tolerance and doesn't attack our own proteins. However, malignant cells will upregulate PD-L1 expression on their cell surface to interact with those T cell PD-1s and essentially evade the immune response being mounted against the cancer cell. However, if nivolumab or one of the other agents in this group are administered, like I'm showing you here, the interaction between PD-1 and PD-L1 is blocked, enhancing T cell activation so the cancer can no longer evade the immune response. And we can continue that attack of the cancer cell by the immune system. So similar to ipilimumab, because we are removing an immune checkpoint, there is going to be a risk of immunostimulatory effects with a risk of autoimmune mediated inflammation, along with the same concerns for hypersensitivity reactions. Again, the immune specifics are not the expectation here, not until block 5, but generally understanding that we have immune checkpoints in place that can be manipulated with monoclonal antibodies to promote immune-mediated attack of our malignant cells. Now we're going to switch gears over to our small molecule inhibitor, which is going to be osimertinib. And this agent is an irreversible third generation EGFR tyrosine kinase inhibitor, which works well in the setting of EGFR activating mutations, as well as mutations that confer resistance to the earlier generation agents like erlotinib and gefitinib. Now, we went over this similar signaling cascade with breast cancer and our HER2 targeted therapies, but we will again review this cascade and add osimertinib in the context of lung cancer. So under normal conditions, this signaling cascade starts with the binding of EGF, for example, to its respective receptor, EGFR or HER1, leading to receptor activation through autophosphorylation of the intracellular domains and downstream activation of signaling pathways like PI3K and MAP kinase pathways, leading to normal gene expression, balancing growth and apoptosis. Now, in the path to malignancy, this involves some sort of change or imbalance in this signaling pathway that leads to hyperactive signaling and the growth, proliferation, and survival going unchecked. In non-small cell lung cancer, this is either amplifications of the EGFR or activating mutations in EGFR that no longer require ligand binding for signaling. And the bonus with the EGFR tyrosine kinase inhibitors, like our agent here, is that these are relatively better at targeting mutant EGFR than normal, ideally helping with specificity and reducing off-target toxicity. Along those lines, though, for ADRs, we will still see some that you would expect with tyrosine kinase inhibitors and targeting EGFR, because there are still some rapidly dividing cell types that will still take a hit, like the skin and the GI tract. And there's a risk of cardiotoxicity with these agents, ocular toxicity, and pulmonary toxicity. And there is going to be a risk of drug-drug interactions with these agents because they are metabolized by our CYP450 enzymes like CYP3A4. Moving to our next slide. So I hope this video has showcased some of the most common non-small cell lung cancer treatment options and their mechanisms of actions and toxicity profiles that are important to consider when devising a lung cancer treatment regimen. I hope this has also highlighted some of the key patient factors and cancer characteristics that need to be taken into account when selecting agents, keeping in mind there needs to be a balance between improving prognosis and toxicity. Another primary takeaway from this video is if you can exploit a driver with targeted options, like with our example we showed today, then there are opportunities to reduce the reliance on the cytotoxic agents. Also keep in mind, we can also leverage the patient's immune system through immunotherapies to provide another opportunity to target the malignant cells with a unique mechanism of action. So remember, we'll continue to build upon this foundation of anti-cancer therapies in future blocks. So take these agents along with those from the CML and breast cancer videos and start organizing them based on mechanism of action and toxicity profile so you can revisit them later.